George, thank you very much. I'm grateful for having been asked to give this talk on role of transcatheter pulmonary valve replacement in native right ventricular outflow tract in children. If you could tell me whether you can see the slides, okay. Okay, thank you. So these are my disclosures. Now, pulmonary valve replacement comes about because of whatever is done at a initial surgery, and the pathways that we come across consist of, for example, in the first 6 months of life, there may be operations that involve the right ventricular outflow tract, where either a transannular patch is used, such as intratracheal fallow, or a conduit is used, be it homographed or other synthetic material, such as in common arterial trunk. Once you get past this stage, in the next 2 to 5 years, we may need to replace the outgrown conduit, or the conduit might have calcified, or in some cases, such as in pulmonary atresia VSD, that may have staged surgery, the first conduit may be implanted surgically. Now, as time goes on, over the next 8 to 15 years, the conduit may fail, or it may need to be upsized to an adult size. And then in adults, there may be conduit failure or development of calcified conduits, which require further interventions. So when it comes to treatment options dealing with all these scenarios, one of them is conservative treatment, which we did do with tetralogy of Fallot with pulmonary regurgitation, and really left things quite late. In some cases, we may limit activity. In some cases, there may be repeated hospital admissions. The other option is surgery, replacing the pulmonary valve, or replacing the conduit. And then, of course, the transcatheter treatment, which is less invasive and possibly feasible in many cases, but leaving the conventional surgery as an option. I mentioned the initial surgery of the heart defects involving conduits or patches. We are really trying to reduce the number of operations in the patient's lifetime when it comes to repeat operations on pulmonary valve or right ventricular outflow tract. Back in 2000, percutaneous melody valve was introduced, and the aim was really to extend the lifespan of conduits, right ventricular pulmonary artery conduits, in order to reduce that number of operations. Now, of the two options, conduits or native right ventricular outflow tracts, conduits tend to be obviously non-compliant compared with outflow tracts with patches, which are very compliant. In conduits, there's a high variability in terms of how they progress. There may be stenoses or calcification or combination. When it comes to imaging, we evaluate these both with MRI scans as well as CT scans. The sizing will depend on the initial conduit size, and by catheter, we will be looking at how we can enlarge those conduits without rupturing them. And the treatment essentially consists of trying to make the landing zone bigger. How do these conduits fail? It's usually because of stenosis progressing and becoming severe. In native outflow tracts with patches, you may have stenoses, you may have calcifications, there may be aneurysm formation as well when it comes to dealing with different types of problems. MRI and CT scans are the imaging modalities that we use, and the sizing when it comes to trying to treat depends on the waste that we may demonstrate using compliant balloons in order to get some idea of the size of the waste to guide us as to what size valve may be used. When it comes to treatment by catheter, we're trying to create a safe landing zone, and ideally you want to make the landing zone as small as it would be suitable for that patient, and possibly less compliant as well, in order to help us put valves in. What are the options? Well, we've got several options now. Things have progressed since 2000. When it comes to surgical conduits, if they're more than 16 millimeter diameter, then Melody valve can be used, and here's a picture of that. If the conduits are more than 22 millimeters, then the Sapien valve here on the top right needs to be used. And in the native large dilated right ventricular outflow tracts, the options are either to pre-stent and implant Sapien valve, or implant the Sapien valve directly. But if they're bigger than 28 millimeter outflow tracts, then this is where the self-expanding valves, and there are a few developments in the last few years that will have an important role to play. Here's a venous P valve that I will be addressing a little bit. Polster valve here, and then the Harmony and the Altera stent combined with Sapien valves. And so these are some of the newish ones. I've put Harmony and Altera in brackets because at the moment they're confined to studies in US and haven't really progressed to Europe and rest of the world. There are issues when it comes to percutaneous pulmonary valve implantation in children. That is the need for large sheaths. The size or the French size of the sheath depends on which valve is being used. Melody valve tends to require 16 to 18 French. Sapien valve can be smaller, but depending on the size of the valve to be used, it may be bigger than 18 French, up to 22 or even 24 French. Venous P valve, the self-expanding one, requires up to 24 French, depending again on the size. This valve, the venous P valve, is available up to 36 millimeter diameter, Sapien 29 millimeter, and Melody 22 millimeters. So the size of the conduit or the size of the outflow tract will really determine which type of valve is best to implant in that child. Weight of the patient will then impact on the size of the sheath that we can insert into the femoral vein or internal jugular vein, and the diameter of the outflow tract or conduit, or the native RV outflow tract, will determine the type of the valve to be used. Here's an example of a child who had repair of common arterial trunk at the age of 5 days, and with passage of time over the next 2 years during follow-up, the conduit, this was a homographed outflow tract, the conduit became stenosed, as you can see here, and so the option was either to replace the conduit or try and rehabilitate this. And so we decided to do a staged rehabilitation. Here's balloon dilation, which really did not open the conduit satisfactorily. This is the angiogram afterwards. And so we went ahead and implanted a Palmer's stent in those days. And you can see here the stent being positioned, and eventually after implant, the conduit has been dilated or enlarged. There is still an area underneath the conduit, which is a bit muscular, that may need to be addressed later on. But the right ventricular pressure had come down from near systemic to just over half systemic at this stage. During follow-up, another couple of years, because of increasing gradient in the subvalvular region, a further intra-stent was implanted inside the Palmer's stent, and this is a 3D reconstruction of that outflow tract now, which has a complete abolition of the gradient. And of course, that results in free pulmonary regurgitation. And then further 7 or 8 years, by now the child is 10 years of age. Here we're dilating that Palmer's stent with an intra-stent inside it, and now we're putting in a covered Cheatham platinum stent in order to dilate this conduit up to 20 millimeters diameter. And you can see now with the CP stent implanted, that's almost at 20 millimeter diameter. And so that then just required a little bit of tweaking with a higher pressure balloon, and that then prepared the ground for us to think about dealing with pulmonary regurgitation. But remember, now we've got this child well into early teenage years. And then at the age of 11 years, here's a Melody valve on a 22 millimeter balloon. We're in the process of implanting that. And there you can see the AP and lateral projection showing an excellent result, almost competent. There's a catheter-induced pulmonary regurgitation. But see, we have rehabilitated this conduit and got many years out of that, compared with how it was at 2 years of age. However, about 3 years later, during some unprotected dental treatment, the patient, this teenager, developed endocarditis and then needed removal of everything and homograft pulmonary valve replacement. Just to show you some data, there's a study from Belgium, Doris Boshoff and Mark Gavilik's team, who reported back in 2013, nearly 9 or 10 years ago now, use of percutaneous pulmonary valve implantation in children. The indications of their population was a conduit-free right ventricular outflow tract, or children with existing but undersized conduits. And they used 21 Melody valves and 2 Sapien valves at that time in the 23 patients. The mean age was 16.9 years, ranging from 6 to 80 years. This is the whole population. I'm going to focus on group 1 patients, which consists of 8 patients. But this was some of the examples of images of stenosed conduit that required pre-stenting followed by Melody valve implantation in, for example, here in a 12-year-old patient. The group 1 had 8 patients who had conduit-free RV outflow tracts because of previous transannular patch repair for tetralogy fallow. Their age range was a mean of 11 years, and the weight ranged between 20 and 67 kilograms. The RV outflow tract diameter was between 14 and 20 millimeters. And after pre-stenting in all of these cases, they underwent valve implantation by catheter. 7 of these were Melody and 1 was Sapien. And ultimately, the outflow tract diameter was a mean of 21.5 millimeters, ranging from 16 to 26 millimeters. So this was one of the earlier studies reported for percutaneous pulmonary valve implantation in children. And here's one such example, again, a common arterial trunk repair with a bicuspidized aortic homograft used, which had narrowed down. And so this had to be redilated. And you can see here with balloon interrogation followed by covered stent implantation, gradually dilated up to a good size, and then eventually a 20 millimeter Melody valve implanted with an excellent angiographic and hemodynamic result after that pre-stenting. For this patient, I'm grateful to Damien Kenny. This was another teenager, 13-year-old patient with tetralogy, double outlet right ventricle. There was left anterior descending arising from the right coronary artery and crossing the outflow tract, as you can see here. The conduit was stenosed, or the outflow tract rather was stenosed with the right ventricular pressure 3/4 systemic. There was fairly severe pulmonary regurgitation with an increased end diastolic volume on the MRI scan and reduced ejection fraction of the right ventricle. So testing was carried out with an Altosa balloon. This is a non-compliant balloon. And at the same time, coronary angiography was performed, and you can see that the coronary artery remained protected or not compressed. And so he was able to then test further and then implant a Sapien 26 millimeter valve through a dry seal sheath. I think this is a 20 or 22 French dry seal sheath. And the Sapien valve's now been fully dilated up to 26 millimeters. And you can see a competent Sapien valve, and then a final check of the coronary artery to confirm that there was no compression. So again, in a child with a slightly challenging anatomy, the result of percutaneous pulmonary valve implantation was excellent. Shabana Shahnawaz did a multi-center US study of 117 patients, again, in children, median age 11 years, median weight 35 kilograms. The original conduit diameter ranged from 9 to 16 millimeters, and the narrowest conduit diameter was between 4 and 23 millimeters, with a mean of 11, after various interventions had been performed. The conduits were enlarged to a median diameter of 19 millimeters after intervention, and the gradient across the conduit was reduced to about 7 millimeters. So the results were good. Here, all of the children had melody valves implanted, so the maximum diameter of the melody valve was about 22 millimeters. The results were good, with freedom from further right ventricular outflow tract intervention of 97% at 2 years and 89% at 4 years. There were 5 cases of endocarditis in this population, so incidence of 2% per patient year. I'm going to show you the native right ventricular outflow tract, and here's an example of a venous P valve in a 28-kilogram patient that I did in Indonesia. So this was an 11-year-old patient who had previous tetralogy of fallow repair with transannular patch at the age of 4 years. During follow-up, there was progressive pulmonary regurgitation, and then patient developed effort intolerance. The MRI showed various diameters of the outflow tract. We carried out balloon sizing, which showed the pulmonary valve annulus was 24 millimeters, right ventricular outflow tract 33 millimeters, and distal MPA 26 millimeters. So we thought after balloon interrogation that we would use a 28 millimeter diameter venous P valve. So here are some angiograms in this patient showing fairly severe pulmonary regurgitation. There's some measurements of the outflow tract. This is a lateral projection showing slightly, not quite a pyramid shape, but some reduction in the diameter near the pulmonary artery bifurcation. And then we did balloon interrogation. Interestingly, there was a waist just below the pulmonary valve, which is due to a little bit of muscular obstruction at just below the annulus as well. And so before attempting a valve implantation, we thought it was best to do further testing with a non-compliant balloon to make sure that the indentation or the waist could be abolished. And so with a Z-Med balloon of 26 millimeter diameter, we were able to abolish that waist and abolish the gradient. And so we carried on with a venous P valve of 28 millimeter diameter, 30 millimeter length. Remember, this is a 28-kilogram patient. Here's some pictures showing positioning of the venous P valve. Then the distal flare is gradually opened and the valve is positioned. And then once we're happy after some check angiograms, as you can see here, the final release of the valve is being performed now. Those markers are where the 3 markers are where the valve is sewn into the self-expanding stent. And there you'll see the valve releasing. And once we're happy with the position, the carrot and the assembly is gradually removed. And then we do the final check angiograms. Here's the right ventricular angiogram showing really unobstructed outflow tract and good position of the valve. And here you see the pulmonary angiogram showing a competent pulmonary valve. And at the time, these patient had a transesophageal echo as well. This was pre with severe pulmonary regurgitation. And here you see very nice movement as well as the flow in the, oh, that's not playing. Oh, there was no pulmonary regurgitation on TE. So I won't go back to the slide where the computer crashed, but that was demonstrating the venous P valve. And I thought I'd just finish off with a few slides of data of a venous P-valve in children. Remember, this valve can be up to 36 millimeter diameter. So it has been used predominantly in adult patients. At Evelina, we've been using it as compassionate use and part of CE study since 2015. The current indications are age more than 12 years and weight more than 30 kilograms. And in our population of nearly 50 patients now, we've used the venous P-valve in 11 children, just focusing on children. The mean age at valve implant was 15 and a bit years, ranging from 10 to 18 years. Mean weight at procedure was 58 kilograms, ranging from 39 to 98 kilograms. And the valve diameter was between 28 and 36 millimeters, with 90% of the valves being more than 30 millimeters in diameter. There were two complications. One was jailing of the right pulmonary artery, where we used a bioptome to pull the valve back down into position. This patient had naturally occurring right pulmonary artery stenosis, so we then carried on and stented the right pulmonary artery as well. And then there was one fracture of a needle that we were doing a Z suture in the groin, and that required a surgical removal. But that, as far as the valve inside the heart was concerned, that was fine. Follow-up ranges from 6 months to 6 years, or nearly 7 years, mean of just over 4 years. And 1 out of the 6 patients who's had fluoroscopy between 6 and 12 months has evidence of a single stent fracture, but the valve function has been fine. And importantly, 7 patients have undergone MRI scans at 6 months to 12 months after the procedure, and the end diastolic index volume has reduced from mean of 158 down to mean of 128 mils per meter squared, and the pulmonary regurgitant fraction is reduced from median of 44% down to median of 3.4%. So excellent results based on our experience. So to conclude, percutaneous pulmonary valve implantation of conduits is certainly possible with good results. But of the larger native, so-called native RV outflow tracts, it is challenging because of the size of the valve and the sheath that is required, but certainly feasible in selected patients with appropriate anatomy. And the patient weight is a limiting factor with self-expanding valves, not just venous, but others as well. And the early to medium-term results have been acceptable. I'll stop there, and my apologies for crashing of the computer. Thank you.
Thank you very much, Shak, for a very nice presentation and quite informative. As I'm sure everyone knows, in the congenital surgery databases, pulmonary valve replacement is one of the most common surgical procedures, certainly in the EXA database. I was reading recently that in the STS adult congenital database, and Kasim Mavroudis is there, he can tell us, pulmonary valve replacement is the most common congenital operation recorded in the adult STS database. So we're very much interested in these developments of percutaneous valve implantation in the native pulmonary annulus. I understand that the Harmony valve and the Altera are not available in Europe. Do you have some idea when they might be available, and what is your view of the future in this?
There's a little hold up with both Harmony and Altera. There are discussions going on for studies in Europe, but there's certainly some delay. The venous P-valve, which really has widened the application, is due a CE mark approval in the next 2 to 3 weeks. And so I think that will certainly open up its use around Europe. The Harmony still has some limitations in terms of diameters. The Altera also, So the venous P valve really getting us up to 36 millimeter diameter gives us quite a lot more scope for usage.
Thank you, Shak. Adoni and Kiri Yanakopoulou.
Thank you very much for your outstanding speech. Congratulations for your great work. It's really promising for our patients to postpone surgery for so many years with so little complications. And it really inspires us for the future and for in our country.
Thank you very much. I have a question from the audience. Actually, the question is if there is an incidence of 1 or 2% per year for endocarditis, that means 1 in 5 kids in over 10 years. That's the question from the audience. Isn't that too much, I guess?
Yeah, so very good, very important question. So this has been one of the concerns with the Melody valve in particular, because that is a bovine internal jugular vein valve, and the incidence of endocarditis has been a concern with it. With the other valves so far, the Sapien and even the venous and the others, Polster valve, the incidence of endocarditis has been much lower and pretty much similar to the endocarditis occurring on surgical pulmonary valves.
Thank you very much.